interrupt me because I do talk very quickly, and sometimes I just get on a roll and I forget to look at questions. So please, we'll keep the raise hand function over on this side. Oh, sorry. Learning curve, learning curve. All right. So this is, we've done a few specialty pathology rounds, and this actually all started based on specifically kidney pathology, just because Mary and Abby and I are fortunate enough to get a lot of kidney biopsies, and not a lot of schools have that opportunity. We've had other specialty rounds focusing on other types of classification schemes for oral tumors and oral pathology, as well as laminitis. I hope to expand this and have more specialty systems. Dr. Permanadan is here at Ohio State, and he has a repro biopsy service, and so he has told us that he will do at least uterine tumors and probably ovarian tumors for us. And Dr. Goldschmidt in January will also do mammary gland tumors as well. So I think that's scheduled, slated for late January. So hopefully we'll get more of these kinds of rounds set up so that everybody has the opportunity to see different types of lesions that might not come through their service. It looks like pretty much everybody's muted. I think we have the opportunity to mute you if you haven't already been muted. But please, like we said, raise your hand if there's any questions. So next slide, please. Okay, so I kind of was making this presentation late last night, as is typical. I thought I was going to pull an all-nighter just like an undergrad, and I made it till 10 p.m. So that's as late as I can stay up. So some of this is probably a lot of typos. I will correct them before I send this out. And just another aside, there's a lot of slides in this presentation. I expect this presentation to probably take this month, and then we'll have another session in the middle of December. And then once both of those presentations have been given, then I will send you guys a PDF of the text and the images. So the first thing I always tell my residents, especially the new residents that are starting, is that even though I look at kidney all the time, I look at the kidney pretty much every single day on histopathology. I still can't tell you which tubule is which with great certainty, except for very specific tubules. The tubules I care about are probably the ones that are the more important tubules to worry about, the proximal tubule. But in general, I really can't tell you which loop of Henle is which. I don't think that it's something that people should be concerned about. I think region of the kidney is probably more important, and I'll show you some examples of that in just a moment. I do have, when I was studying to be a nephropathology fellow at UNC, I assumed the MD nephropathologist always knew if I pointed to a tubule that that was the ascending thin limb versus the descending. And so I was like really trying hard to figure out which was which, and I was studying before my fellowship, and I got there and they literally looked at me and asked me why I cared. So again, the proximal tubule is more important because that's where most of your absorptive function is. If you have damage, if you have early acute tubular epithelial injury, it is going to happen predominantly in the proximal tubule. There are a few hints that can tell me I'm in the lower portion of the nephron, but in general, I'm just worried about looking at the proximal tubules. So if I'm seeing a tubular epithelial cell that has a prominent brush border, I assume it's a proximal, well, I know it's a proximal tubule. And then if I have a cross-section of the tubule, it's going to be the convoluted portion. If it seems to be a more linear section, then it's going to be the pars recta. Depending on what species you're looking at, if you're looking at RAS, it's called the S3 segment. But it's basically the straight portion of the proximal tubule. And so those are the clues that tell me that I'm seeing a proximal tubule. Obviously, we come to an issue when we're looking at injured proximal tubules because they lose their brush border. So we'll talk about that in just a moment. If I see a tubule, especially a linear tubule that's lined by cuboidal epithelium, then it has to be a collecting duct. And then I basically say whether it's a cortical collecting duct if I'm in the cortex, and I say it's a medullary collecting duct if I'm in the medulla. And so in general, just to let everybody take a sigh of relief, nobody really cares which side of the loop of Henle. We just know anything else in the middle has to be a loop of Henle. And then I also like to talk to the first-year veterinary students that we have recently kept identifying segments of the nephron. So when I was in vet school, I was not taught about this section here. I was not taught about the connecting tubule. I don't know if anybody was taught about the connecting tubule. So I'm not sure if it was just I wasn't taught because nobody cared to teach it to us, or if it was because it didn't really quote unquote exist yet as its own segment. I think it's because if you look at the literature, it really hadn't been identified in until 10 years ago. So this segment right here is a new segment that they have just started to do a lot of research at, and it's actually quite important because I hope everybody remembers from vet school about the macula densa talking to the glomerulus for the tubuloglomerular feedback. And so the macula densa tells the glomerulus to either let more blood flow through or keep blood out, depending about the GFR. And the connecting tubule is quite cool because basically it has its own connecting tubuloglomerular feedback. And it says, hey, I know the macula densa told you to rev it up a little bit, but I'm going to tell you not to rev it up so much. So the connecting tubule basically titrates what the macula densa tells the glomerulus to do. So if the macula densa tells you to go one way, the connecting tubule is like, yeah, not so much. So I just think it's fascinating that we still don't know everything about the nephron, and that's why the kidney is the coolest organ on the planet. Okay, pretty much every slide will end with that statement, by the way. That's why the kidney is the coolest organ on the planet.
Rachel, is that thing linked by vasculature or by nerves?
So it's interesting, you actually, if you had this, so the question here was, how is this connecting tubule signal transmitted to the glomerulus? Yes. So if this were actually drawn correctly, this connecting tubule would be right near the macula densa, and it's all molecular. And so, yes, it's peregrine. And I think that they're still trying to figure out exactly how that works. Okay, so along with the same theme that I don't know what tubule is which, I do think that one thing we can easily or often identify is whether we're looking at a medullary ray versus a cortical labyrinth. And I think that now when I look at studies or I'm looking at large cross sections of kidney, this is kind of more about how I differentiate the two. And I think this is something that Dr. Brown, Kathy Brown, does at Georgia as well with her CAT studies, is trying to say, are we looking at something which is going from the cortex to the medulla? So it's called a medullary ray because it runs towards the medulla. And if it's a straight tubule that's running towards the medulla, it's going to be in the medullary ray section. And then if it's this intervening part with glomeruli, it's going to be in the cortical labyrinth. So I think that is one thing that we may not know which tubule is which, but at least we know we're in a straight portion running towards the medulla. So I think everybody could identify that on histology and say it's a medullary ray. And so the medullary ray is composed of the pars recta. This is the proximal tubule pars recta. LOH for me means loop of Henle, and then collecting duct. And usually right in the middle of the medullary ray is the collecting duct that's going from the cortex to the medulla. So I think that's something that anybody can see on histology. And then the cortical labyrinth would be the intervening portion. It is, if you get just the right cross-section through a kidney, you can get these these medullary rays completely along their length. But sometimes they kind of dive in and out of the field just depending on how you're cutting them. And then I always misspeak, so I do try to correct myself for this situation, is that the papilla is actually just the tip of the pyramids. So I often say this whole thing is the papilla, but I'm incorrect in using that terminology. So the pyramid is this kind of triangular structure going from the medulla running down towards where the renal pelvis is, and then papilla should just be the tip. And Dr. Weisberg is giving me eyes, so I want to know what his question is.
Relative to this then, do you have a way of trimming in a kidney when you get an entire kidney? On what plane you make your cuts?
So that's a very good question. So if you were to have maybe an autopsy case or a nephrectomy sample, what is the best way to trim a kidney? And I probably should take pictures of that. I prefer a cross-section right through the middle so that I'm getting where the ureter and pelvis is visible. Obviously, you know, tumors or scars are going to affect that. But in general, I actually prefer both kidneys to be longitudinal section, although that's not the way we do autopsies here. So we do at Ohio State. Hey, I just did an Ohio State we. That's kind of fun. Versus a Penn we. They get mad at me for that. So at Ohio State, we do a left being a longitudinal section of the kidney, and then the right being the other perpendicular plane. So you would have more of a circular section.
Midline longitudinal is what you would recommend.
Midline longitudinal is what I prefer. It gives me more tissue to evaluate. It's just my being greedy. And so, but I can understand that if you're on the autopsy floor and you have which kidney is which, the left versus right is easy to do the way we do. Obviously, bovines and horses, you're never going to get all of that. So, but I do want to see where the papilla and pelvis are, papilla and pyramids are going into the pelvis. Any other questions? Okay. And so whether or not these pyramids fuse tells you whether it's pyramidal, unipyramidal versus multipyramidal, and then each pyramid will have a papilla, so you'll have a multipapillary or unipapillary. And then in some species, like in dogs, I think everybody remembers that the dog kind of looks like this along its long axis. And so it ends up, sometimes we call it a crest, but I think it's still the same concept. A calyx is a part of the pelvis that basically cups the papilla or the pyramids, and a lobe would be the pyramid right here and the cortex that's overlying it. Sorry. So this would be an example where this is a cross-section of a dog kidney. This is a normal dog, healthy dog, 2-year-old dog that was just taking kidneys for normal kidney specimens. Out here is the cortex, and then here are, you guys can highlight, because of the vacuolation and the arrangement of these tubules, these are the medullary rays. And so in this particular section, they're kind of diving in and out of the field as they go linear towards the medulla out here. So sometimes if you get really lucky, you'll see it right as it's the whole length of them. But this is just an easy way to kind of see how they're running linear towards the medulla. And then they still have in between them the glomeruli and the cross sections of the tubule. So that would be the cortical labyrinth part. Okay. Any questions about myth 1? I don't care which tubule is which. No, that's not, I do care. I'm just not really good at identifying it. Okay. So this is my myth 2. I have to fight really hard for this concept. I have taken the word nephrosis. It's still mentioned in Jubb and Kennedy, but I specifically say it's no longer the appropriate term. And I understand it's really easy to say, and everybody, everybody uses that word, especially when we're talking about large animals. People still say nephrosis. I don't think it's the correct term, and if you say this word to a nephropathologist MD, they will look at you like you have, I don't even know if they've ever really heard that word. So in the MD world, they talk about acute tubular necrosis, and that was probably in the 90s, maybe up to late 90s, early 2000s, they still said acute tubular necrosis. My residents will hear me, and they'll use the term a lot, ATN, acute tubular necrosis. It's very easy to say. It means technically what nephrosis was supposed to mean, that the tubules are necrotic. And then I would say there was probably a change in the textbooks in the human literature, probably in the early 2000s, which said that you can have significant renal dysfunction even if you don't have overt necrosis of the tubular epithelial cells. And it would be due to the fact that they're losing their brush border, so the proximal tubules are losing their brush border. And so now in the human literature, they even in their discussions of this concept, they say, hey, we understand acute tubular necrosis was the term we used 10 years ago, but now the term is acute tubular epithelial injury. Sometimes they just say acute tubular injury. And so most of the MDs will use that as their diagnostic term. However, it's pretty funny because they still say in their ICD-9 code or their in their parenthetic portion for acute tubular epithelial injury, they'll literally be reading out a diagnosis saying, okay, this patient has acute tubular epithelial injury, in parentheses, ATN, even though N isn't in, you guys understand the acronym isn't correct. So ATN is just easier to say, and that's kind of their reminiscent of, we always knew it was ATN, so we're gonna say the N even though we're now changing it to epithelial injury.
I guess why injury was preferred to degeneration.
So the question is, why is injury preferred to degeneration? I don't know the evolution of why they did that. And I guess I could ask, but so yeah, very well possibly. So one of the comments is that maybe even you don't have histologic degeneration, but you could have ultrastructural evidence. And so they didn't want to use the term degeneration.
That's a functional diagnosis rather
It
than
is.
a morphologic diagnosis, because to me, injury includes necrosis. I mean, but
It does. So, and I think that this is, so the question is it appropriate for pathologists to use a functional term when we actually should be talking about a structural change, which is either degeneration on the spectrum to necrosis / apoptosis. And I don't know, I should ask. I'll ask Dr. And I don't know if I'd be able to figure it out, but I can ask. I think Fogo is the one that writes this at Vanderbilt. Okay, this is another thing I always have to say, and I think, I guess I trust the MDs on this. So I was taught that if you had a tubular basement membrane, it should shunt you, or it should direct you towards an ischemic process, or absence of a tubular basement membrane should say ischemic versus presence of a tubular basement membrane should say toxic. I don't think that's true at all. And I think that there are plenty of situations where you could have toxic injury, especially in the situations where you have crystal formation and tubular rupture and tubulorhexis, where you will have a damage to that tubular basement membrane. So the presence or absence of a tubular basement membrane is not pathognomonic of anything. And so it might, I'm really kind of looking at the cell phenotype, and obviously the history is going to factor a lot into that. So I still think if you have really significant coagulative necrosis, then I would still be on the ischemic fence. I guess, I don't even know if I could say that. So just strike my last comment. I apologize for that. So yeah, so, and I don't ever really put a whole bunch of stock in whether or not the tubular basement membrane. I definitely comment about if it's there or absent in my reports, because obviously if it's there, we have the opportunity for regeneration. And if it's absent, it's going to be really, you can't regenerate that tubule, but I don't know if it tells me about pathogenesis. Dr. Weisbrod is also giving me eyes again.
Well, it's useful also to talk about cellular aspect versus tissue aspect. In other words, you're talking at the cellular level. Clearly at the tissue level, if we saw coagulation, necrosis of the cells of the epithelium and the interstitium and the blood vessels, we wouldn't go toxic.
Correct. Correct. So that is a very good point. So what we're talking about, if you're looking at an entire region that has necrosis of the tubular epithelial cells and it's extending, and you have evidence of interstitial damage, peritubular capillary damage, and oftentimes after these guys, if they live long enough to have reperfusion, you're going to have neutrophils kind of coming in the peritubular capillaries. Then you're going to have evidence for ischemic coagulative necrosis. Yes, okay. I think that any biopsy report should indicate the percent of tissue that's involved by tubular injury. So I usually tell them, very scattered few tubules comprising less than, 5% of the tissue, because I think that helps you kind of correlate it with clinical parameters. Okay. So I know Mary has muted herself, but I would hope Mary will raise her hand and speak up for anything that I misspeak. And this is kind of where we are in assessing tubular injury. Obviously, there's a huge push from the pharmaceutical industry to get the most specific, sensitive, early indicators of decreased glomerular filtration rate. And obviously clinicians want that as well. And so we want to find out when we're hitting the kidney before we have our typical elevation in creatinine. And so obviously we could do a GFR study, but that's not going to be done in a very easy way, especially in clinics. It's just difficult and time consuming, and not a lot of people do a GFR study. And so we've always used creatinine as our surrogate biomarker. I rarely ask about BUN. I don't really know if somebody gives me that piece of information. I kind of don't pay too much attention about it. Dr. Radin is here. Is there a thing where BUN would outweigh your concern for, like a BUN that would outweigh your concern based on creatinine? Or how do you interpret the two of those?
Well, sometimes BUN can be influenced by other things, so that's what you need to be cognizant of.
Okay, so yes, that's the comment. If you have an elevated BUN and maybe the creatinine is normal, so the BUN obviously has a lot of external factors that are influencing it. So I guess maybe the consensus, and Mary, maybe you'll speak up. I wouldn't diagnose acute kidney injury based solely on BUN because it could be influenced by other factors. Is that a true statement? I didn't misspeak, Dr. Radin? Okay, and Mary also says yes. Okay.
Yeah, and I don't ignore BUN if I have it, but I agree that I don't use it exclusively ever. But if I have a high BUN and creatinines in the reference range, I look closely at the creatinine to make sure, and you'll get to this next, that it truly is normal for that patient. If it is, then I think of extrarenal factors for BUN. If it's not, then I think BUN might be a better indicator in that patient of a decrease in GFR.
Okay, yep, thank you. So it's one of the things that's difficult is, especially when we're talking, even when we're teaching this to vet students, is that we give the vet students a measurement, and then we give them a reference range, and it's just very difficult, I think, at this stage to think that our reference ranges are 100% adequate for each patient, because obviously creatinine is going to be a function of muscle mass of that patient. And Mary has been excellent about when I started reading kidney biopsies, if I said, oh, the creatinine's within the reference range, so it must not be acute kidney injury, blah, blah, blah. She would point out, oh, it's Yorkie, so a 1.3 in a Yorkie is actually probably not a good value for that particular dog because they don't have much muscle. How are they making a creatinine that high? And we do that as well in the human field. So if we're thinking about a creat from an 80-year-old woman who has a creat at like 1.3, 1.4, she just has no muscle mass. So how is her creatinine that high? And so that's different than a bodybuilder. Their creatinine is going to be trending high because they have a lot of muscle mass. So I think that I don't know if there's any goals in the IDEX and tech world to start to get breed specific or maybe body size specific creatinine reference ranges. But and then I think the other thing is that, and Dr. Navdi talked a lot about it when we were at ACVP, is that trending might be more sensitive to detect acute tubular injury. And so if we happen to be lucky enough to have a baseline creatinine, and I mean, oftentimes I would think we're probably using baselines from a few months ago. Those are fine baselines. And so maybe the patient was in for a regular checkup a few months ago that got blood work and then all of a sudden presents again, and now the creatinine has gone up. It may not be out of the normal reference range for the entire laboratory, but if it's increased over its baseline, then that might be more sensitive for decreased GFR. Did I misspeak for any of that?
No, that's
I think you got it pretty well.
Humans were subject-based references, which means you have your baseline and then watch your trend over time.
Yes, yeah. Okay, and so we do have iris staging for different types of disease. So, and I think that they have done some of this editing. So if anybody ever wants to know what type of stage of kidney disease, go to the IRIS website. It's very well thought out, separated for cats and dogs about CKD. But I think that we always emphasize to the clinicians that it should be done on a patient that's stable. not a patient that has any kind of evidence of dehydration, that kind of thing. The patient has to be stable for you to do the staging. And so it'll say if you have a creatinine less than blah, 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 then you must be in CKD stage 2. And then they'll also say, is the patient proteinuric? And they give you cutoffs to proteinuria. And then they say, is the patient hypertensive? And they give you cutoffs for that. And so you would have a stage 2 with proteinuria without hypertension. And that would be your stage that you could follow that patient for. And I think that Mary, am I misspeaking that they're going to possibly add in SDMAs for the iris staging?
Well, they've already added a minimal bit of SDMA in there, meaning that if SDMA is persistently above 14 micrograms per deciliter, you could count it as stage 1, even if there are no other clinical signs or laboratory data to support kidney disease, and also to help use it with muscle mass. So if creatinine is lower than you'd expect for the patient, or like there's severe muscle wasting, then you can look at SDMA, and if it's above a certain value, it might mean that you should treat based on the next stage up.
Okay, so I think that will be, and like I said, it's on the website. So we're going to talk about SDMAs in just a second. There's a little forecasting there. And so then I thought it was interesting because I was writing the slide up last night and I did the AKI staging. So I went to go look at the IRIS website, and I think they make a good point that it's not a staging for AKI, it's a grading. And so because the animal's not stable, so it wouldn't be in a stage of disease, it's a severity of AKI. And so that's why we use the term grading for AKI. And again, the cutoffs are based on creatinine, and a lot of it's based on increases in creatinine over a period of 48 hours. So you could grade, oh my gosh, this happened, they spiked their creatinine, they might be an AKI grade 1. Okay, so what's up with SDMAs? Did I just type that? Yeah, it is. So this should be SDMA, I apologize. So the actual molecule is symmetric dimethyl arginine. And it is a breakdown product of methylated arginines, and these are usually proteins that hang out in the nucleus that have their arginines methylated. And so most of these are nuclear proteins, and so they're going to be broken down at a very specific constant rate. And this proteolysis happens fairly constantly, and it's going to get released into the blood. And it should be excreted entirely. They say pretty much entirely by the kidney. It's really filtered across the glomerulus and has minimal reabsorption by the tubules. And so because this is a nuclear protein and not a muscle protein, muscle mass shouldn't really have the same impact that it does in creatinine. Does that make sense to everybody? Am I speaking right, Dr. Radin?
Yeah.
Okay, she says yes. I should have had you sit closer to the conference phone. I forgot how much clip out there is. So the question is, how do we know about what it is in severe inflammatory disease? They've looked at it in humans in the ICU, and so that's usually what they say in the literature when they refer back to what other examples do we have, or what other scenarios where SDMA should be used. And so they've shown that SDMAs in humans in the ICU go up before creatinine would go up if they're going to eventually have acute kidney injury, or if they have evidence of acute kidney injury. So it might be a good marker that this would accumulate in the blood if you can't pee it out. Am I speaking right for that too, Mary, about ICU patients in humans?
Well, and I think the question on inflammation is also about could it go up with inflammation without necessarily having a decrease in GFR? And I think we don't fully know that, but so far the studies support that when it has gone up, it's correlated quite well with GFR. We don't really have the studies in animals to look at that closely yet. Yeah.
And they have, I mean, this is, I would say for people prepping for boards, I mean, there's 5 papers on this in the past 1.5 to 2 years. And so they've looked at it in cats. It seems to be a very earlier marker of decreased GFR. They've looked at it in dogs. They've looked at it in the Hills dogs. They looked at it in your Alport's dogs, right, Mary?
Right.
And so, and that's it. That is a model of kidney disease. So they've looked at it in models of kidney disease in dogs and the normal just dogs that like live in Hills Colony and eat their Hills food. And the Hill study is actually, I like the Hill study because it talks about we put them on different diets and protein level, or sorry, the different quantifications of the diets actually didn't really influence SDMAs. And so, and it doesn't seem to be impacted by age, whereas creatinine was, I think is what the Hill study ended up saying.
Except for puppies, but yeah, the older the dog,
right, puppies,
it doesn't seem to influence like creatinine muscle mass would.
Okay, and we have a question over here.
So is it too early in the identification of this biomarker? Is it starting to be recommended to be used in staging or in preventative screenings?
So in this situation, what are we doing now with this information? So this is offered on the regular chem screen from IDEX. So if you're running blood, right? Am I, sorry, okay, good. So if you're a practicing practitioner and you're sending blood work out, and it will just come on your regular chem screen. And so, and they do the little blurb like, oh, you know, it seems to be an early indicator, blah, blah, blah. I think for our scenarios, like in university hospitals, it's still something we have to send out, correct? And they have to pay specifically for the test?
Yes.
And it's like 20 to 30 bucks, maybe? 20 bucks?
Yeah, I think it's $20 from IDEX and then whatever the markup is for the university.
Oh, okay, so somewhere around there. So we would have to request it specifically. I don't think Antec is requiring or is reporting it because I've gotten blood work from Antec for biopsies and I haven't seen it on their list. And then I think Mary said they've had a couple of changes in the IRIS grading scheme to say if your SDMA is already up by this, even if your creatinine's not up or you don't have other evidence of kidney disease, you would still be in IRIS stage 1. And has to be repeatable. Very good point.
Yes.
So it can't just be one up. You have to basically document that it's repeatable. Okay. Yep.
Still, it's a timing-based indicator, right? It's an earlier indicator of acute tubular injury.
No, sorry. Sorry, I apologize. SDMA is an earlier, well, it seems to be an earlier indicator of decreased GFR. It does not necessarily mean tubular injury or acute tubular injury.
And I think
it would be up, but it's not just, it doesn't tell you what type of disease. It just says that the GFR is decreased.
And I think it's an earlier indicator, at least based on what I know so far, because of the not having the muscle mass influence and seeming to be uninfluenced by, at least so as far as we can identify other factors, other major factors.
Yeah, so it doesn't seem to have other external influences that our biomarkers have. Okay. So I think everybody can agree that this is acute tubular necrosis. I think this is this sheep that had a septic infarct. So I think these are not the scenarios anybody really worries about. Am I going to miss this diagnosis? And you can see, I can still maintain, I can see the tubular basement membrane. It's pretty intact. So, and this guy had a big, huge thrombus in his arcuate vessel. Okay, so, and this is another one where I think we could probably get out. This is a toxic injury. This is, I think this is a cat that ate lilies. And so, again, we can maintain our tubular basement membranes. You guys can see them right there, and then we have necrosis of this, probably 2 nephrons were hit in this particular field. There's more nephrons up here that were hit, but these guys are okay. It's pretty patchy as far as which nephron was hit. I think what's cool is the glomerulus looks completely fine. I don't know if that's the glomerulus for this nephron. I can't tell you that. But this glomerulus is sitting right amongst these necrotic tubules, and he's doing good. Okay. So this is actually from Heptonstall's, the more recent version of Heptonstall's pathology of the kidney. And so obviously we all got the necrosis of tubular epithelial cells. It could be coagulative, eventually it could go to liquefactive, but these are all other features that if we're looking at a biopsy that's well preserved, that we're gonna either look for to say there's evidence of injury, or even once I see evidence of injury, I'm going to make sure there's no oxalate crystals in there. I'm going to make sure there's no tubular excess. So these other features are really important, especially if you're looking at a well-preserved specimen.
When you talk about dilation, ectasia of the tubular lumina, Do you mean that to be real, or do you mean that to be a change in height of epithelium?
So that's a very good question. So the MDs have specifically always commented on this, although I haven't done the study. So they say that this lesion here, dilation of the lumen, is actually technically what's going on because we've sloughed our apical brush border, and now our proximal tubular epithelial cell is basically a cuboidal shape. It's no longer a tall columnar with an apical brush border. So now we have this clearer, more open lumen, but the tubular basement membrane circumference shouldn't have changed. That's what they say. There's plenty of times where we'll just be talking very quickly amongst ourselves, or sometimes I'm typing really fast on a biopsy report and I'll say dilated tubules, and I won't be correct because I should be saying dilated tubular lumina. I think there's times where the tubules get dilated too. Like I think, especially in an obstructive process, they're gonna eventually have to expand their tubular basement membranes. But in general, even if you just see loss of the brush border and a more open, cleared lumen, that can be evidence for tubular injury. Again, in well-preserved specimens, and I hope to do the study where I actually quantify how much time it takes for an autolysis to lead to sloughing of the brush border, and so hopefully we'll get that at least, we'll look at that, hopefully. That's my summer project. Okay, so here's some examples. If you are looking at a preserved specimen, this is a PAS stain, so it's highlighting the tubular base, or the apical brush border. It also highlights the tubular basement membrane. So if you're looking at this, this is a convoluted tubule you want to see. This is a proximal tubule you want to see. You want to see so much chamu in here, you really can't tell that there was a lumen. These guys are good proximal tubules. This guy has lost his brush border. He's got some cells hanging out in his lumen. I feel like the entire tubule is a little dilated. And so, you know, this is one of those scenarios where I'm supposed to say dilation of the lumen, but in general, I think the whole outside proportion is also dilated. But having this open lumen is concerning. And this patient, these pictures I'm showing you are from patients that were all azotemic. This is what tubular atrophy looks like on the PAS stain. So the wiggly, thickened, hyalinized PAS basement membranes. And then you can sometimes have either attenuation of the epithelial cells, or sometimes they're just smushed together. So because this is an irreversible change, I always say how much of the tubules are atrophied, because this is not coming back. This guy can come back. He can heal. This guy can't come back.
It's completely sloughed, and how you saw it still proximal tubule, uniformly sloughed.
So the question is, if it's uniformly sloughed, like sloughing of the brush border, how do you still know it's a proximal tubule? That's a very good question. Sometimes it's based on location. Sometimes it's based on, if you're in the cortex, about 70% of those tubules should be proximal tubules. So sometimes you're not saying, okay, this one's definitely a proximal tubule. You're just looking at the entire field and saying, I can't find a brush border to save my life. You know, these are, so sometimes it's just not having any brush borders at all in all of the tubules. You know that those used to be proximal tubules when they sloughed their brush border. Plenty of different examples. So here is an H&E stain of an animal that has pretty good tubules surrounding the one single injured tubule, which is right here. I take note if I see 2 to 3 dead cells hanging out. These guys have jumped ship, and they're undergoing what process residence when they detach, but they're still viable, and then they die in the lumen? Anoicus, yay. Anyway, so I have the benefit of only having to look at a single core or 2 single cores. I completely understand when you guys are looking at autopsy specimens and you have huge cross sections. Like, it's going to be really hard to pick this up unless this is at every single tubule. So I'm looking at a very small area of view, and these are things I comment on my report. Ryan, do you have a question?
No.
Okay. Dr. Jennings is just stretching. He's not questioning me. Again, now we've got, this is kind of closer to the medulla. We've got a lot of interstitial fibrosis in this particular picture. This is, again, an H&E slide. And we have a tubule here that is definitely stretched out, and he's got fragments of cells in his lumen. So, and then, you know, this guy is kind of happy but floating in here, and he's probably just detached from an earlier part of the nephron, and now he's floating further down, and he will die soon. Death is imminent. Okay. And then we have, this is actually a patient that, I think this is the dog with minimal change disease, Mary. And so which is not a common diagnosis at all in dogs, so please don't jump to that diagnosis. But this particular dog had severe evacuation of the epithelial cells. It's all microvesiculation. These vesicles are all smaller than the nucleus, so it's microvesicular change. We've lost our brush border. This guy still maintains his brush border. This guy maintains his brush border. And then the tubular lumina are quite dilated, and it's lined by a very attenuated epithelium that has microvesiculation. So again, just other ways that we could say, hey, this is not a normal tubular compartment, and there must be something going on with the tubular compartment. Okay, so then you get to this question where you're like, okay, well, now we're looking at a cross-section of kidney. This is a cross-section of a dog kidney. And I'm, you know, sitting with my residents, and I'm like, is this autolysis? Is this acute tubular necrosis? You know, I'm not really sure. I have to figure out how fresh this dog was on the floor. And so, you know, I've got some tubules that have hung on, and they look completely good. And why would this tubule hang on, but this other tubule lose all of his cellular lining? And why would these cells start to swell? You know, I don't know if autolysis could do this. This is a dog that actually has acute tubular necrosis. This is a very fresh specimen from a dog that died after eating one of those little flame things underneath the chafing dishes from catering. The residents that took their exam from me last year recognize this picture, hopefully, because I gave it to them on the test. And so, you know, it is a lot of times like, how fresh is this dog? Is this autolysis? Is this ATN? And, you know, to me, I would have always gone ATN based on the fact that some of these guys are checking out and other ones look completely normal. So I don't know how a specimen would autolyze that way.
Now, there's about a half a dozen tubules in here that have stainable brush borders, but very conspicuous lumens.
Yes. Well, this brush, so the question is, we have some tubules here that have very thick brush borders and no lumens. We have some here that do have brush borders, and they have very conspicuous lumens. I don't think that's a thick enough brush border, and I also think that, you know, we're probably cutting into the thickness of this tubule versus this one's a little bit more linearly arranged. So I can explain my way out of anything based on, hey, it's section of cut, but you know, we want to see a brush border about that thick. I mean, this one has too much lumen, and he's got a really good brush border. I also should comment.
Would you use that as support that maybe the other changes are real?
Yeah, so could I use the fact that some of these have maintained very good brush borders as support that this is not autolysis? Is that your statement?
Well, I'm going the other way. The fact that I've got at least a stainable brush border, but a dilated tubular lumen, does that suggest that other tubular changes in the field may be real?
So the question is, I have a stainable brush border, but I have a dilated tubular lumen. Does that tell me that changes in the rest of this field are real?
Does it suggest?
I can't say. I'm hoping to do this study over the summer to say how much, like, if you were to biopsy an autolyzed dog, what would your sample be? I think I had an interesting case, this case that came, the Doberman that we're working at, Dr. Nabdi and I are working at. So it was an autopsy specimen. They basically euthanized the dog. They took both kidneys out immediately post-euthanasia. Did I say Dalmatian? That's what it was. And they took both kidneys out post-euthanasia within a few minutes. The owner was a nurse, so the owner was okay with that. They sliced only the right kidney, and they took a couple of chunks from the right kidney to put into fixative for EM. And then they gave me the left kidney completely intact and did not make a section in it at all. Those tubules look great. They look great. I mean, there is probably a few soft tubular epithelial cells, but or a few, yeah, there's a minimal amount of autolysis. And that was shipping a completely non-section kidney in formalin for 3 days. So, you know, it is, might be just the fact that it got out of the dog very quickly and got placed in the formalin very quickly. That seems to be a bigger deal. So, I mean, that's kind of what inspired me of like, hey, let's really look at this. Like, do we really know how much autolysis should let us lose our brush border? Okay, ClinTap people are bored. So I think I can get through the end of this one and then we can, or we'll probably get halfway through this one. Okay, so I did hear somebody as I went into one of the receptions, Rachel's here, hide your kidneys. And so I don't want everybody's kidney biopsies. I really don't. I mean, especially if you're biopsying for things like, we tell everybody don't biopsy a cyst, don't biopsy an abscess. And then obviously don't biopsy for mild changes in clinical parameters unless they're sustained. So I've had a few times where we've gotten biopsies from clinics and they did not call ahead of time. And it was literally like, oh, the patient was isoscenuric, it was a puppy. So then we brought it back in a month later, did the biopsy, and at that time, we also took urine at the time of biopsy, and the patient's no longer isoscenuric. So they probably shouldn't have biopsied that dog. They probably should have repeated the UA before they did the biopsy. And so if it's sustained inability to concentrate urine on a puppy, then that might be an impetus to at least do an ultrasound exam. And if the ultrasound shows that the kidneys look abnormal or abnormally shaped, then we might be dealing with some kind of abnormal development. But in general, I don't want anybody to send me kidney samples for mild changes unless they're sustained. I am somewhat worried with the SDMA stuff that I might be getting biopsies for small changes in SDMAs, and I hope that people will call beforehand because I don't know if that would be worthwhile biopsies. These things are expensive. People ask me how much they cost. My evaluation, just by what I do for EM and immunofluorescence, and then Mary doing the urine protein electrophoresis work, we charge $645. That's just for that evaluation. You're also thinking that you are anesthetizing the patient, doing an ultrasound, you've got an ultrasonographer there taking the core, and so you've got a lot of work up for this patient, so it's a very expensive procedure. So I would say the most common indication or most common reason we get a biopsy is pretty much subclinical proteinuria. We do have some patients that do have full-blown nephrotic syndrome, nephritis being more of an inflammatory, a nephritic patient. And then oftentimes we get some that are puppies that are suspected for either quote-unquote renal dysplasia or quote-unquote juvenile nephropathy. Okay, so nephritic is the one I'm going to start with just because it's first, and this is these patients for nephritic glomerulopathies, I guess I should say, not just nephritis. So nephritis would just be inflammation of the entire kidney, and these are ones that we're going to have evidence that there's glomerular damage. So they're going to have proteinuria. It can be very, very variable, but it's usually in the nephrotic range. I use that term a lot. So nephrotic range to me.
Would you give a definition of nephritic glomerulonephritis?
So these are the features. So it's going to be something that has glomerular injury, but then also has an inflammatory component in the rest of the kidney.
Cells in the glomerulus?
So I separate nephritic glomerulopathies from nephrotic syndrome or nephrotic glomerulopathies.
I understand.
So nephritic glomerulopathies, I've got evidence of glomerular damage based on the proteinuria, and I have evidence of inflammation in the tubulointerstitial compartment. Yes, and we will compare this to nephrotic, and then I think we'll be done for the day. Okay, so proteinuria, nephrotic range for me, I say over 2.5. I think some people say over 3 for the UPC. So oftentimes we'll say, well, it's definitely in the nephrotic range. It's enough that we would be concerned, but they don't actually have nephrotic syndrome. So nephrotic range doesn't mean that they have nephrotic syndrome. It means that they've got a UPC greater than 2.5. Urine sediment in nephritic patients it's almost always active, so they're gonna have a little bit of hematuria. Dogs and cats don't have as much hematuria as humans do. They might have some white blood cells in their urine. They might have a lot of casts. I think I'll have to add the word cast in this. I mean, they might have casts from their tubular damage. They can be hypoalbuminemic. They don't have to be. they're almost always azotemic, but the azotemia could be fairly mild, and again, if we're using the trending, then we probably would pick up more azotemia in these kinds of cases. We usually see some degree of hypertension, and it can usually be quite severe. So if I have a patient that has proteinuria, has maybe a little bit of azotemia and hypertension, it's going to fit more into this kind of clinical presentation of nephritic. And then the edema usually, like peripheral edema, sometimes you usually don't see that. Okay, that's going to be a comparison to nephrotic syndrome. So nephrotic syndrome is that thing we learned about in vet school where they have proteinuria, they have edema/ascites, whichever one, they have hypoalbuminemia, and then they have hyperlipidemia. I think I was taught hypercholesterolemia. I think hyperlipidemia is probably more accurate because it could be variable lipid parameters that could be dysregulated, not just cholesterol. And again, this is that same proteinuria cutoff, somewhere between 2 and 3. It kind of depends on which paper you're reading. It can be quite high. I think our record so far is 42 for UPC, and so it can be quite high. We've saved 2 patients with UPCs over 40, so I don't know if we saved them, but they're not dead. Okay. So, okay, so these are the features of nephrotic syndrome. There is a paper out of NC State which looked at patients with nephrotic syndrome versus patients that had the same degree of proteinuria but did not have full-blown nephrotic syndrome. So they had the same degree of elevated UPC, but they didn't have all the parameters of nephrotic syndrome. The patients with nephrotic syndrome did worse. Maybe it's because it's more difficult to manage some of these other features like the dyslipidemia and the ascites, and so that might be why they did worse clinically, but it is important to say, do they have full-blown nephrotic syndrome or some component of nephrotic syndrome, or are they just all severely proteinuric? Nephrotic patients usually have a bland urine sediment. They sometimes they don't have any azotemia. We've had some patients that have gone many months or even a year without azotemia, and then it could develop later. And then hypertension, most of the time absent. Although I don't really know if I have 100%. Yeah, I think it's usually absent. Okay, so then we have the subclinical renal proteinuria, and so this is kind of nephrotic syndrome and subclinical renal proteinuria are the two, how do I want to say this? They're basically on a spectrum. So if they have a UPC greater than 2 to 3, but they don't have all the components of nephrotic syndrome, and they're really not showing symptomology of the fact that they have an elevated UPC, we click this tab on our website that says it's a subclinical renal proteinuria. They're not showing demonstrable signs of the fact that their UPC is high. Again, these patients don't usually have any active urine sediment. If they had active urine sediment, then they probably would go into the nephritic category. Again, these guys could be hypoalbuminemic. They don't have to be. Usually they're not azotemic. Can be absent. And so this azotemia, it doesn't really matter. It could be there. If it's moderate, usually they're probably going to be in the nephritic category. I probably should change this. I think I have this from an old slide. So usually the azotemia is really not there. And if they did have moderate azotemia, we'd probably put them in the nephritic category. I'm actually thinking I did take this from I took this from Dr. Lee's slide, so I apologize. And so I'm not really sure about this hypertension. These things will be edited. This must have been my last slide at 10 p.m. last night. By definition, they won't have edema or ascites because if they had that, then now they're all of a sudden clinical for the renal proteinuria. So the azotemia and hypertension, I'm not really sure how that falls out. Usually they're not going to be striking if they're present. And then why would you recommend a biopsy in these patients that really have no clinical signs of their renal proteinuria? And again, I should comment on the renal part. You've excluded any lower urinary tract inflammation. You've excluded any kind of systemic signs that would have caused them to have a really bad fever or something like that. You've excluded pre-renal proteinuria and you've excluded post-renal proteinuria as your causes. And these are protein loss specifically because the kidney is damaged. And so you might want to recommend biopsy because the UPC is quite high. And if the UPC is high and the creatinine's low, you have a better chance of identifying a cause that you could possibly correct. So you have a better chance of being able to intervene. And then sometimes they'll basically monitor the UPC, and if the creatinine starts to creep up, then they'll recommend a biopsy, or sometimes the UPC just doesn't decrease even though they're doing the standard therapies like ACE inhibitors, they're on a low protein diet and they're maintaining blood pressure. If the UPC doesn't decrease in those scenarios, then they probably would say, okay, we've tried for 4 months, now we're going to recommend a biopsy. Okay. And then our last ones are, we do get biopsies because they're worried about a pedigree with juvenile onset disease. So juvenile onset disease doesn't have to be overt abnormal kidneys. It doesn't have to be renal, quote unquote, renal dysplasia. But it could be something where they have a mutation in one of their proteins in their podocytes, or maybe a mutation in their glomerular-based membrane. And so they will be developing evidence of renal disease at 1 year of age or 2 years of age. They didn't have maldevelopment per se, but they have some type of problem with their molecular structure of their glomerulus often. So it might be really helpful for the pedigree, but it really doesn't actually end up doing much for that particular patient. I guess maybe it just gives you more justification to push hard with the low protein diet and monitoring blood pressure. Like, it might give you some idea of like, hey, there's not a lot of functioning tubulointerstitial compartment at this stage, so this patient's going to progress more rapidly than maybe his litter mate. So it might give you some idea of how fast it's going to progress, but it doesn't necessarily often say, oh my gosh, now I would, treat this way versus the other way. Sometimes we do just get the biopsies when they're going to do the spay and neuter for those dogs. So we'll get like an opportunity biopsy. We do get a couple of biopsies when they're already in late stage 4, IRIS stage 4 or stage 3. So we do get a couple of those biopsies. We usually tell the clinicians not to biopsy those patients because it really isn't going to be able to change any of their treatment. In those scenarios, we don't advise for a biopsy, although sometimes they'll still biopsy because they'll be like, well, now the owner wants to do everything, and they will go ahead and biopsy that dog. And the other situation is maybe it's been trending up for a creatinine and all of a sudden it'll spike, or maybe all of a sudden the UPC has, trended and then the UPC elevates as well. So sometimes it's just like, oh my gosh, this didn't track the way I thought it was, and now I'm going to biopsy. I don't really know how much it helps from a clinical standpoint. Do you have any other comments on glomerular processes? These are mostly, actually I shouldn't say they're all glomerular. Obviously these guys are glomerular processes. The juvenile onset could be still tubulointerstitial. Do you have any comments about reasons for biopsying, Mary? I think Mary has muted her. Yeah,
no, but I've also had a little participant in the last 10 minutes.
Oh, is Remy saying hi?
Yes.
And then our last one we're doing for AKI, this is our last point for this myth. I actually ended on a good time. So we do biopsy for acute kidney injury. So that would be the grading scheme that we talked about for our IRIS. Oftentimes, if we have an inflammatory process, we could see a glomerulonephritis, especially if they're proteinuric. It could just be inflammatory with just an interstitial nephritis. Usually when I see just interstitial nephritis, I think of leptospirosis. Sometimes it could be chronic nonspecific inflammation, although my long-term career goal when they write on my tombstone is I'm going to figure out tubulointerstitial nephritis in cats. And then if you already suspected lepto, you probably would already be treating. In humans, they would definitely biopsy for a concern for interstitial nephritis because humans have a lot of weird allergic responses to drugs and xenobiotics. So they would want to demonstrate this patient has an allergic reaction to the NSAID we just put the patient on so they can have reasons to stop the NSAID. We don't really know if animals have that same type of allergic responses to drugs. We do see biopsies that are for acute kidney injury, and then we diagnose a non-inflammatory process, most likely acute tubular necrosis, and that might tell us if we can see a certain type of crystal, like maybe it got into ethylene glycol, maybe it was supportive that this patient had Lilly exposure. So I think for non-inflammatory processes, it might show you like, hey, look for a toxin, go back and take a really good medication history. If I see it in an inflammatory process, then we could say, hey, you actually missed that this patient really had glomerulonephritis. You might want to immunosuppress, or no, this just looks like lepto. So those are usually supporting biopsies and not necessarily like, oh my God, I figured out the the key to what was going on. These are usually, yeah, I support your diagnosis that this patient had Lilly exposure. Okay, any other questions? I think that's a good thing. I think I have to start next month, if that's okay, if everybody still wants to join, about myth 4.
I have a question.
Oh, we have one question here, yes.
Sometimes I see interstitial information that's sort of linear, like it's tracking along the medullary rays. Is that?
So the question is, if we see ascending, I usually call it ascending or radiating bands of interstitial inflammation, and what does that mean? So it's a very good question. The problem is that it could be that there was pyelonephritis that tracked up to the cortex. It could also be that that particular nephron had some type of process, whether it was mild obstruction that caused to that particular collecting duct. If you kill off one collecting duct, the MDs have just told me that they just did the study. If you kill off one collecting duct, it usually kills about 2,000 nephrons in humans. So somehow, it's not that all 2,000 are emptying into the same collecting duct, it just means that you block one, that collecting duct and its associated nephrons are going to expand because they're obstructed, then they're going to compress on the peritubular capillaries and decrease perfusion to the neighboring nephrons, and it can basically kill off about 2,000 nephrons. So eventually as that kind of spreads. So that's the thought. Maybe you just had one process that hit one specific collecting duct. There was damage to the tubular basement membrane, and we do think that urine has a back leak. The urinary filtrate can back leak out into the tubular interstitium. Those tubular epithelial cells that are damaged from the obstruction do secrete a lot of cytokines to recruit macrophages when they're damaged. So it might just be not that you had a pyelonephritis that only hit that one region. It might be you just damaged that one region a long time ago, and they're just continually attracting macrophages and lymphocytes. And that's why it's radiating. Does that answer your question a little bit? So I guess the answer is I don't know. That I see that all the time and I don't know about it. I just comment on it.
So you do describe that pattern.
I do say though, I say radiating a lot in my diagnoses. Any other questions? Any questions from the outside world? I talked a lot. Outside world, no questions? Okay. If you guys have more things and you want to send me an email, that's great. This has been recorded, right? Mary?
Yes, yes.
Yes, okay. So anybody, obviously if you've attended, you probably don't want to sit through this again, but if your classmates were not able to attend, then we can share that link with them. Okay, thanks guys.
Thanks, Rachel.
Thanks, how's everything going? Good?